Thanks, Martin. So it's just really fantastic to be up here. I've followed Martin's career since the days at MD Anderson. Peter and I get to work together a lot, and I'm excited to get a look under the hood and see how you guys do things. So this talk is a bit more clinical, so without further ado, this is where I hang out. Everything's big in Texas. This is the Texas Medical Center. It's the largest medical center in the world, as they tell us. It's also the largest single employer in our county, Harris County. So this is our new campus. It's we're.
You can use it pointing on the mouse.
On the mouse. Yep. Okay. There you go. Okay. So this is our McNair campus. Pretty much the entire clinical enterprise has moved over there. We're building a new hospital. Our clinics have been there. It's really been a nice place to work, and this is sort of the future of at least our clinical practice. I wear a bunch of different hats. These are my financial disclosures. I don't think I'm going to be discussing anything that's relevant to that. If I do, I'll be sure to mention it during the talk. So this is what I'm going to try to cover in, I guess, about 45 minutes, and I'll hopefully leave some time for discussion and questions if you have them. This is going to be a bit about primarily muscle-invasive bladder cancer and cystectomy and sort of the steps leading up to it and sort of how we optimize outcomes. So we'll talk about, these are the goals of the radical cystectomy. So it's really local regional control. So a lymph node dissection is sort of part and parcel of that, and we're going to talk quite a bit about that. We've got to get accurate pathologic staging because that drives prognosis, obviously. And ideally, and so I've been training with Don Skinner. So Don, it's interesting. If I'm doing a radical prostatectomy and I ask people who Pat Walsh is, it's astonishing. First of all, raise your hand if you don't know who Pat Walsh is. Okay, so no one's going to raise their hand. The pediatric urologists don't count. But it's astonishing to me how our residents, and certainly not anyone in the room, sort of miss out a lot on the history. So Don Skinner brought continent diversion, I'd say certainly to the United States, maybe North America. I had the privilege of training with him and sort of drinking the Kool-Aid. And so ideally, we would do a reconstruction that allows patients to retain volitional control, avoiding if that's possible. Obviously, we want to protect the upper urinary tract and sexual function preservation. So the so-called trifecta of muscle-invasive bladder cancer surgery. And the goals are the same. It's an anatomic operation regardless of how you do it, whether you do it open, robotic, Laparoscopic, whatever it is. So our guidelines, we spent a fair amount of time on this when we wrote the original muscle-invasive guidelines. I think that was a few years ago. It was a nice collaboration between all of our multidisciplinary teams, so ASTRO, ASCO, and the AUA were involved in that. And so this was sort of the general outline of what we wanted to communicate to urologists who are performing this operation. And but you'll see that it's a clinical principle. So the levels of evidence supporting some of the things that we do are not where they should be. And we'll get there, I think, eventually with some of the work that's been ongoing. And so I'll go through a fair amount of this during the talk. Like a lot of things, when I first came back to Baylor after my fellowship in '92, you did a radical prostatectomy, you had this big incision, patients were staying in the hospital 5 to 7 days, and you just sort of learn how to do things differently, advances in anesthesia, advances in perioperative care, and the same thing has happened with radical cystectomy. We're still stuck with kind of a fixed mortality rate at about 90 days, and it varies depending upon the center. We're operating on older, sicker people, and it's as much of a GI operation as it is a retroperitoneal and pelvic operation, but we'll go through some of these things during the talk. So there's some facts, if you will, supported by pretty high quality research, and so Outcomes are just generally better with more experienced surgeons and hospitals that have a lot of experience in this. And when we wrote the trial that I'll talk to you about, we put in some very specific metrics that the surgeons had to meet in order to be able to put patients on the clinical trial. I understand in Canada, not every place has alvimipam. This is the peripheral new opioid receptor that's been somewhat of a game changer in terms of both, I guess, maybe prevention and resolution of ileus, shortening hospital stays. And there's been some really interesting research. I'm not going to go into the data from Urs Studers, particularly doing randomized trials of volume restriction and alpha agonists and reducing both intraoperative blood loss, need for blood transfusions, and reducing the sort of perioperative volume overload and edema that used to be sort of part and parcel of this operation. And it's cutting off the bottom of this. I'm not sure why. I'll show you the data, but minimally invasive surgery has generally been shown to be equivalent in terms of early oncologic endpoints. I'll show you that, but not really a statistically significant improvement in perioperative outcomes when you look out to 90 days. And then the quality of the node dissection is related to really local regional control and, of course, accurate pathologic staging. And so I'll just throw all of this up there. You can see the date on this publication is now 10 years old. But what the beauty about the system that they've had in place for a long time at Memorial Sloan Kettering is an institutionalized way of categorizing really everything that happens in the perioperative experience. And so their data is about as good as it gets, I think, and has been shown by others that about 2/3 of the patient will have one or more perioperative adverse events or toxicities. You can see that the majority of them are Clavian grade 2 to 5, and the majority of them occur within 90 days. So when I'm reading the literature and listening to people talk, I'm not only interested in 30-day outcomes, but I really want to hear about 90-day outcomes. Yes, the majority of the events occur within the first 30 days, but you can have some pretty significant major toxicities that occur within that 3-month period, and we're stuck with this sort of 1 out of 4, 1 out of 5 patients get either readmission to the hospital or a trip to the ER for things that just happen after this operation. I just discharged a guy that had a perfect as one could be, post-operative course in the hospital, discharged him, came back a few days later, had a little hematoma, opened it up in the clinic, and then the next day spikes at temp. He was in the hospital for 10 days with sepsis, and I still don't know where it came from. Things that are beyond our control, but we know how to take care of, and he'll be fine moving out. And then this is a pretty wide range. You could make an argument if you're sitting in front of a patient and if you're quoting a 1 out of 10 probability that they're going to be dead 90 days after their operation, you'd never do the operation. You probably shouldn't do the operation. So, but those are published data. It's probably more in the range of 4 to 6%, but some of those are patients who rapidly progress. If you operate on enough of these patients, you see these rapid progressors. They're really scary. So, but embedded in that are some cancer-related deaths, but the majority of these are directly related to the surgery. And so this is something we need to continue to work on by proper patient selection for surgery. I'm not going to get into it today because we do have another alternative of chemoradiation therapy that urologists have been somewhat reluctant to embrace. And there's going to be a very interesting meeting with a combined effort from the AUA and the Johns Hopkins Greenberg Institute, really focusing on bladder preservation next month in Baltimore as this gets to a little bit more traction. Bernie Bachner, who you may know at Memorial Sloan Kettering, also trained with Skinner, did a trial where it was a randomized study of a minimally invasive radical cystectomy versus open, and their primary endpoint was 90-day morbidity or perioperative outcomes. And essentially what he showed was that there was no difference. They actually stopped that trial at a planned interim analysis because it was a futility analysis, which means that there was no way that based upon the data that they had, it was pre-specified, were they going to show their primary endpoint of a 20% improvement. Now, the critics of this would say that, well, they were doing the diversion open. So they did the experimental arm was a minimally invasive radical cystectomy, and then they had an incision to do the diversion. Now, this was done long enough ago before sort of intracorporeal diversion reconstruction has taken on a bit more, I hesitate to call it mainstream, but a lot of robotic surgeons are doing this more facile than they were at this point in time. And the cost at that time was higher for the minimally invasive approach, regardless of the type of diversion that was done. And then fast forward, there's a brilliant guy named Dipin Parekh. I don't know if you all know him, but the guy's like double, triple bordered in. He's a whiz-bang general surgeon, a fantastic urologist, went out and got a master's degree in public health, and he's been chairman at University of Miami now for a few years. But Dipin got an R01 grant to do a randomized clinical trial of, and in this case, same design, but with a primary oncologic outcome. And they completed their study. It was 15 centers, multi-centers, so that's more of a gold standard rather than a single institution trial. They enrolled a lot of patients who had early disease, and so that's going to favor the oncologic outcome. You can see the primary endpoint, 2-year progression-free survival and a non-inferiority margin of around 15%. And what that means is that they wanted to show that they could at least meet the so-called bar of oncologic outcomes with open radical cystectomy. And much like Bernie's trial, every patient had an extracorporeal diversion. And you can see that there was no difference, so they met their primary endpoint in terms of 2-year PFS. So this is really the first high-level evidence to suggest that, and I would make an argument of an early oncologic outcome, because you need to follow these. I learned this when I was really trying to do my outcomes research in somewhat more of a crude environment when I started my faculty job in 1992. I learned that you really need to follow these patients out 4 or 5 years to get the true oncologic outcome. Now, we're not going to talk about it today, but perioperative chemotherapy pushes the time for relapse out to 2.5 years, maybe even to 4 or 5 years post-op. And so I would say this early oncologic outcome was the way the trial was designed, favorable patients, but here's the data. And so at least the quality of the surgery in terms of the anatomic extent, the number of lymph nodes identified by the pathologist, and here you have the oncologic outcome, seems similar, at least in this multi-center trial. So now we're going to go back to what a lot of people are concerned about is how are we teaching our trainees to do a proper TURBT. And so you might, what's the big deal here? It's an easy operation, it's endoscopic, it's, we do this with our hands tied behind our back. And actually, it's not an easy operation. And to do it right, to maintain the integrity of the bladder, but really important to get all of the information that you need to make decisions about risk stratification, about treatment, and about ultimately, whether the patient needs a cystectomy or not. So just an example, did a cystectomy on a young guy earlier this week. First occurrence, gross hematuria for a year. Not sure why that didn't get evaluated before this, but he's got a tumor in the diverticulum and he's got an exophytic component coming into the bladder. So I operated on him and he had multifocal disease, not just around the diverticulum. There was tumor in the diverticulum that was high grade pathologically, but it wasn't safe to resect it, I think for obvious reasons. While I was able to resect all of the extra diverticular component, I couldn't get that out, and it was all T1 high grade. So he would actually fall into a very high risk category. But by doing that extensive TURBT, I was able to determine that I think that he would be best treated with a cystectomy. Obviously, I don't have his pathology back, but so we need to understand histology. We need to understand the presence or absence of variant histology. We need to understand whether there's lymphovascular invasion, which would increase the risk of lymph node metastasis. Particularly in a patient with a high-grade non-muscle invasive bladder cancer, we need to understand the status of the rest of the epithelium, right? Because CIS is visible only half the time. Do y'all have enhanced cystoscopy, blue light, or NBI? So that helps us. And then I'm probably a lone wolf, not a wolf, but a lone proponent out there in a case of a muscle-invasive bladder cancer in a male doing TUR biopsies of the apical prostatic urethra. Why is that? Because that's where there's the highest concentration of prostatic ducts. That's where you're going to see CIS. And urothelial cancer in the prostate, when you do whole mount step sections, is present in about 40% of patients, believe it or not. Similar to the presence or absence of adenocarcinoma of the prostate. And so that patient could potentially have a T4 tumor, prostatic stromal invasion, and it wouldn't be visible. And that obviously changes the stage, changes the recommendations for the need for neoadjuvant chemotherapy. But just as important, I use that information when I'm doing an orthotopic neobladder, because the incidence of a positive apical urethral margin is essentially near zero when there's no CIS at the apical urethra prostate. And then we want to do biopsies of the bladder neck in women for the same reason when we're considering an orthotopic neobladder in that patient population. So these, at least in my opinion, are the essentials of doing a high quality TURBT prior for decision making. Okay, so this is known to all of you, but obviously we need to understand very clearly the stage-specific outcomes, in this case disease-specific survival, and you could go to any paper and it would be quite similar. But you can see the dichotomy between organ-confined, so that would be up to T2, and non-organ confined T3, T4, and then similarly for lymph node metastasis. And so there's 2 points here that are fairly obvious, that lymph node metastasis drive outcome. If you take all comers with lymph node metastasis and you can stratify outcome by whether they're organ confined or non-organ confined, roughly about 2/3 of those patients are at risk for progression. So these are the patients that need perioperative chemotherapy. But the other thing is that a single positive lymph node in the true pelvis, especially if you have an organ confined cancer, has a 50% probability of 5-year survival. So I'm putting this up as a prelude to talking about the quality of the lymph node dissection. So the other sort of problem that we have in this disease is kind of crappy staging tools. So even with the use of PET-CT, our cross-sectional imaging isn't really good enough to identify patients who have, say, small volume or microscopic disease outside the bladder. So this is a nice study that was done when Stephen Culp was a fellow at MD Anderson, and then they validated it or tested it in a test set at USC. And I'll show you a figure in just a second from a smaller study that we did, where there's lots of information in that primary tumor that tells you a lot about the risk for occult metastatic disease. So we just talked about a locally advanced cancer, so T3, T4. Variant histology, particularly micropapillary, particularly small cell neuroendocrine, lymphovascular invasion, all of these things increase the risk of occult metastatic disease and identify patients that if you were going to try to risk stratify about giving neoadjuvant chemotherapy, this would be the group that you would give it to. Again, not part of the talk, but the level 1 evidence does not discriminate based upon risk stratification. This is just one institution's effort to try to identify a lower risk patient population that may not derive the full benefit or may not need neoadjuvant chemotherapy. Tomorrow, we'll talk about molecular subtypes as an example of trying to further own in on that risk stratification. And this is just the figures from their paper, which showed that this nice stratification between low risk and high risk. And then we took a look at that in our own patient population and showed something very similar, but a smaller study. So you can, if you're of the mindset that rather than give neoadjuvant chemotherapy to all, there probably is a group of patients for whom they're primed to do better, to do just as good without it, but that doesn't meet the bar of high-level evidence. This would be hypothesis generating, and we can build that question into our clinical trials to try to get more precision around the risk of occult metastatic disease. There's nomograms to help us. We spent a lot of time on nomograms earlier in my career, and they're very useful because I'm sure you know a lot about nomograms, but it gives an individual weight to a particular covariate, and then it makes it relatively easy to go inside that nomogram and assess the risk, in this case, of occult metastatic disease. And we did a validation study and published that a few years ago. So these are some tools that can use primarily clinical and pathologic data to try to identify those higher risk patients and that may derive the full benefit of chemotherapy. This was a nice paper published by Dante Rescue quite a long time ago. You might look at it and it may seem rather mundane today, given the ubiquitous nature of next generation sequencing, but this was a small study that developed a gene expression model for predicting lymph node metastasis. Now, when we went back and we had published a nomogram that looked very simply at T-stage grade and I think one other factor, and it had a very similar AUC than what Dan showed in this model. But fast forward, we now have the tools to use bioinformatics and next-gen sequencing to try to get around this question, or get closer to this question. So I think one of the, I'm not done with the talk, but just to kind of summarize where I've been so far is that it's really critical for us to understand histology and risk factors and try to individualize patients more of a sort of a personalized medicine approach. Nomograms can help with that, and the future is upon us in terms of next generation sequencing, molecular subtypes, and the like. So let's go to a case. It's always good to have a case early in the morning. So this patient came to me with a high risk, okay, so extensive involvement of the lamina propria lymphovascular invasion, and without the CT scan findings, I would put this patient in a very high risk category, and probably based upon that information alone, proceed with radical cystectomy. One of the things that a lot of us get concerned about is this notion that radical cystectomy is only appropriate for patients with proven muscle invasive disease, or the patient who progresses, say, with a high-grade T1 after intravesical BCG. And so I think that there's a very appropriate place for what some would call early cystectomy. I like to call it appropriate timing of radical cystectomy. Peter's, I can't tell if you're nodding or shaking your head. We called Martin because I hear that Martin's a fan of extended pelvic node dissection. Well, that's for another day. And you can see his pathology. So, and he turned out to have a positive lymph node. And so, again, I think I got it right in that particular patient. He obviously, the extended node dissection, whether or not that provided any benefit to him or not is unknown, but we found that positive node, and he's got a much higher risk for progression after this, driven in part by the micropapillary. That would be a red flag. So if you were seeing this on a board exam, I would argue that the correct answer would be a radical cystectomy. You could also, for the residents, could you make a case for giving that patient neoadjuvant chemotherapy? So a clinical T1, high-risk features. Anyone want to? Go ahead.
I just want to ask a question. Like,
Yeah.
will your med-oncs give neoadjuvant chemo for T1 with like bad factors, like extensive LVI? Like, those are all.
That's what he's asking you.
Well, I don't get to choose that. Yeah.
No, we don't. Because, as you may be aware, the entry criteria for the large randomized clinical trials required muscle invasion. But I do know at MD Anderson they would give this patient neoadjuvant chemotherapy, and you could argue that based upon the pathologic findings, that may have been the right thing to do. Now, at this point, this patient becomes eligible for adjuvant therapy trials of IO, immunotherapy, with a positive lymph node. And so the reason I showed this case is because the importance of accurate pathologic staging in the radical cystectomy specimen. Now we know that this patient has at least a 50% probability of progression, not being cured with a cystectomy, and can go on to an adjuvant trial. Yeah.
Would you look for HER2 status in this patient?
The reason for that is because that's been associated with micropapillary histology, trying to think if I'm going to sort of briefly touch on this tomorrow, but HER2 targeted therapy hasn't quite panned out in bladder cancer yet. There have been trials, but I think that, but the short answer to that, Martin, is no. But I think to your point, doing sequencing on this patient at this point might be a good thing to do in the event that they fail so-called, let's say they go on an IO trial or they get adjuvant chemotherapy. Be good information to know at this point.
Seth, are you doing a PET CT on all of your bladder cancers? And what tracer are you using?
Well, right now it's FDG for bladder. But I don't know if you have this problem in Canada, but I had a very annoying phone call yesterday. We have this peer-to-peer business with the private third-party payers. So I wanted a PET CT on a patient, getting ready to do a cystectomy on him, and they wouldn't approve it. Blue Cross Blue Shield.
We don't even ask.
Well, I don't have a choice. So this is. Okay, I understand. Because there's no way in hell you know what the answer is. So I thought I would be clever and say, look, I'm only going to speak to an oncologist because this has worked before. I don't want to, no disrespect to the pediatric urologist, but you get a pediatrician on the phone and they're not going to be particularly helpful. And they said no, because there's no CT abnormality that would necessitate using a PET CT to adjudicate that, even though the patient's last CT was in October. And it's like, wait a minute, you get a CT, you get a functional study, this could be good. So we get them probably on the majority of patients when we can get them approved. And I think the particular sweet spot of PET CT, or at least FDG, which is what we have to work with in bladder, is in the patient who has, a suspicious finding on a conventional cross-sectional imaging. So, if you've got a 1.5 centimeter node in the common iliac region, and it's FDG or PET positive, not that we really need that to drive decision making about chemotherapy, but it's helpful to know ahead of time. It's a whole nother lecture around sort of the utility of PET in that setting. So just so everybody knows, the node staging system changed actually quite a number of years ago. M1 used to be common iliac lymph nodes. It's now retroperitoneal lymph nodes, N3 common iliac, and N1 is a solitary lymph node in the true pelvis, and multiple lymph nodes in the true pelvis is N2. And what's interesting, Bernie Bachner sits on the panel that does all this excellent work for the AJCC, and I asked him, how did you guys come up with this 12 lymph node minimum? And it's not a data-driven exercise. It's data-driven, but it's not high-level evidence. But there's a metric out there that says you should have 13 or more lymph nodes in your cystectomy specimen in order to get accurate staging. I'll show you some data that we have.
Isn't that as much or more pathology-driven than surgery?
So what Martin is asking about is it's both.
But pathology,
That's both, because
I would make 12 become 20.
I'm sorry, what did you say?
I could make 12 nodes become 20 nodes if you want.
I just buy him a coffee.
So when I came back to Baylor, let's see, if we run out of time, we run out of time. But so the first few of these I did, I was getting these really low lymph node counts. Remember, I'd spent a year operating with Don Skinner. So I called the pathologist and I said, look, here's what I'm doing. When I was at USC, the average was like 25 to 27. You're giving me 10 lymph nodes, and I guarantee you there's more in there. So my point is that we're investing all of this time in the operating room because our professors are telling us we got to do it this way, right? So I'm making that investment. I want you to make that same investment. I want you to look at every single bit of tissue that I give you. I expect you to do that. And then identify all the lymph nodes. So there's two verifiable factors in there. One is, it turns out, for some odd reason, maybe you can explain it, is if you give the material to the pathologist in packets. So Skinner, everybody knows who Don Skinner is. You nod your head, yes. So his classic paper, which I guess is from the 80s, a meticulous lymph node makes a difference in outcomes. Okay, so he taught us not just to be thorough, but an en-bloc dissection. So the bladder and lymph nodes would go out to the pathologist in one. Yeah, there's some separation. But Bernie Bachner showed that if you send it to him in packets, so external and internal obturator, for example, right and left, they identify more lymph nodes. And the more lymph nodes you identify, right, the higher the likelihood is that your pathologist is going to find those pathologically proven lymph node metastases. Okay? And then the other thing is, what does a pathologist call a lymph node? Right? So to your point, you can take a lymph node like this, chop it up, and it becomes 3, right? But more importantly, you got to look at everything, and there's fat, solvents, and all this sort of stuff, these tricks that pathologists have to identify all this stuff. The key is that we're collaborators, we're working together, right? And the more information I give the pathologist, the more conversation we have, the more they know about what I'm looking for, the higher the likelihood is that we're going to get as accurate pathologic staging as is possible. And then the other revision is that perivesical lymph nodes, which actually are probably associated with a worse outcome amongst lymph node positive disease, were added to N1, and there were some differences in the stage grouping, where some patients who previously were AJCC stage 4 moved into stage 3. That's probably more relevant for our clinical trials than anything related to sort of the actual clinical practice. Surgical margins make a difference, and so an anatomic sort of wide to narrow operation is really critical to minimize the risk of positive margins. You can see the dramatic difference in outcomes with the Kaplan-Meier plot on the right. And I think all of us who do this operation, when you see a patient where the tumor has sort of penetrated through maybe the anterior wall or the peritoneum, those patients have a bad outcome in general. But the nice thing about it is that it's actually a relatively infrequent event. In this patient population, it was just under 6%. And you can see that patients who had positive margins had similar outcomes as patients who didn't undergo a radical cystectomy in the first place. So we have to, again, it's independent of whether we're using a minimally invasive approach or an open approach. The anatomic aspects of this are the same. So the outcome in patients with positive lymph nodes is driven by, we already sort of had this conversation, the number of lymph nodes identified. There's this thing called lymph node density, which is the number of lymph nodes divided by the total removed. It's sort of a composite number, and then the pathologic stage of the primary tumor, which I already mentioned. So this is, there's been many elegant mapping studies. This was just one that we did, and it simply shows, and you can look at the top, it goes to T2, T3, T4, and then the composite. But you can see already in patients with pathologic organ-confined cancer who have positive lymph nodes, you see lymph node metastasis outside the true pelvis. Okay, so anatomically, then the question becomes, and we can just cycle through T3, T4, and then the composite. You can see that almost up to 30 to 35% of patients who have positive lymph nodes will have lymph node metastasis outside the true pelvis. And then it becomes a scientific question as to what's the benefit of, of extending the node dissection and removing those. This is probably the most elegant work that was done from Germany, which was prospective mapping. And they too, on the right, showed that there were positive lymph nodes in the extended template. But the other issue is that you can't rely on the anatomic relationship of lymph node metastasis to the laterality of the tumor doesn't, I mean, it exists, right? But crossover happens often enough that it makes a very strong case for a bilateral node dissection. This is just our data that reflects the rest of the data that's published. So what this first bullet point says is that if you do a thorough true pelvis node dissection, what we would call a standard, you recognize the anatomy on the right, common iliac bifurcation distally, complete removal of all of the potential lymph node bearing tissue in the obturator fossa, not just above the obturator nerve, but below it, down right to the distal branches of the hypogastric vein. That'll identify the overwhelming majority of patients who have at least N1 disease. Okay? So skip metastasis are rare. What does that mean? That means that if I just do a thorough pelvic node dissection, true pelvis, and they're all negative, roughly about 5 to 7% of patients will have lymph node metastasis outside the true pelvis. Common iliac would be the most common, presacral. But like a lot of things, you don't do 100 operations to sort of find those handful of patients that have disease outside the true pelvis only, but it does occur. And then with the extended node dissection, and you can argue whether that ought to be aortic bifurcation, IMA, or if you listen to Harry Herr, where the ureter crosses over the common iliac. I think Studer sort of has a similar approach. You're going to increase the lymph node yield, which is going to increase the probability that you'll find lymph node metastasis. And I mentioned already the third of patients who have positive lymph nodes beyond the common iliac bifurcation. This is an elegant study. Beat Roth at that time was still with Studer. He subsequently did a fellowship with Colin Denny at MD Anderson, and I think went back home. And this was, they injected a radionuclide imaging agent into the bladder and then mapped all the areas of lymph nodes, not just lymph node metastasis. But you can see this curious absence of anything between the ureters. That's because, anybody know why? Well, the obvious thing is they didn't remove those because Studer has very strong feelings about preserving the hypogastric plexus that comes into that area, both in terms of continence. And this is a very smart guy who's been a student of this his entire career, but having practiced in a different environment, learned from Skinner. We do this all the time, and patients have I would argue, have similar continence. But at any rate, that's why that's blank there. And then you've seen this map both in radical prostatectomy, and obviously this is cystectomy, showing the importance not just of conventional external iliac obturator, but also the internal iliac lymph nodes that need to be dissected as well. And very similar to what I just showed you from our own data in terms of the perceived benefit of an extended node dissection. So years and years and years ago, we had this consortium of, it was Hopkins, UT Southwestern, and Baylor. We were all sort of small shops. None of us felt like we had enough patients on our own, so we combined forces, put together this database. We published quite a bit out of it. But this was one attempt to try to figure out sort of an optimum cutoff of number of, and I'm going to use the term number of lymph nodes identified by the pathologist. Because of the point that Martin made and we discussed already, it's not, well, how many lymph nodes did you find? It's like, well, I just took out, it was an anatomic operation to give the pathologist the best chance to identify things. And what we identified was that if you had 25 lymph nodes in the specimen, you identified 3/4 of the patients with node metastasis, but to get to 90%, you had to have 40 lymph nodes. Now, this is retrospective. You would argue, we'd like to think that these are high quality surgeons, large volume hospitals, but it just shows that, it suggests that the quality of the lymph node dissection and the quality of the pathologic evaluation will drive detection of lymph node metastasis. This is really important in the setting of neoadjuvant chemotherapy. So this was the randomized trial from the Southwest Oncology Group that randomized patients to 3 cycles of MVAC plus cystectomy versus cystectomy alone. And this was an analysis by Harry Herr that showed how lymph node metastasis drive outcome, and how the number of lymph nodes in that study that were reported drove outcome within each of those categories. Okay? And you can see the Kaplan-Meier plots there. And so the patients did worse if they had less than 10 nodes. And you have to remember that was, what does 8710 means? That the trial was activated in 1987. So a different era, and maybe the quality of the surgery wasn't as good across the Southwest Oncology group, but at least some suggestion that also in the setting of neoadjuvant chemotherapy, it matters. Why am I saying this? Because as surgeons, we have I'm not talking about research, but as clinicians, we have some opportunities in this disease to theoretically make an impact by doing high quality surgery. If you're not prepared, this is maybe for a different audience, but if we're taking this on as a surgical specialty, we can have potentially a pretty important impact on the outcome for that patient, not just quality of life, but also oncologic endpoints. And I think this speaks to that in some respect, even in the setting where they're going to get neoadjuvant chemotherapy. If you look at SEER data, these publications are a little bit now several years out, but NX means that there were no lymph nodes in the specimen. So essentially, no lymph node dissection has really pretty negative impact on cancer-specific mortality. You can see the difference between N0 and N1. These are pathologic endpoints, and highlighted there. And then in overall mortality, it's somewhat intermediate between N0 and N1. So again, some insights into the impact on overall survival. A good quality lymph node dissection has a profound impact on local regional control. So you don't know this history, but when back in the, 40s or 50s, when at Memorial, when they started adding a bilateral node dissection to radical cystectomy, the local pelvic recurrence rate dropped from 40 to 50% down to 10 to 15%. So this operation also has a significant impact on local, regional, or pelvic control. And then this is just some more SEER data suggesting that the benefit of overall survival with more lymph nodes in the specimen. So I need to get to the, let me just go through this. There we go. Okay, so I showed you this figure already, and we would argue that this should be the standard of care that's in our guidelines, a high-quality bilateral pelvic node dissection, so external, internal, and obturator lymph nodes. And the question is should that be a standard of care? And that's a scientific question that we can address in the context of clinical trials. So this is just the guidelines showing that we've communicated to the community that a bilateral node dissection is important, particularly when we're going for curative intent, and the anatomic extent, again, a clinical principle. So this is really important because there's no level 1 evidence to support anything other than this. And the evidence supporting a bilateral lymph node dissection is lots of evidence suggesting, again, local pelvic control is improved substantially, and I think hopefully I've made the case for accurate pathologic staging. So when you look at other cancer types, so pancreatic, esophageal, 2 studies in esophageal, and a classic paper in gastric, they had the same question that we ask, is more better, okay? And in the case of, I'll just use the gastric cancer as an example. This is in Japan, New England Journal of Medicine paper. They showed that not only did it not improve outcomes, there actually maybe was a worse outcome in some patients who had an extended node dissection. So they too, in these settings, lacked high-level evidence to support it. And then, so this is where we're sort of getting to in terms of this clinical trial. We actually, somewhat naively, did a study years ago. This was David Esrig when he was at USC, actually started at Yale. Actually, he started this when he was at Yale. Wrote an R01 grant to do the P53 targeted therapy trial. Most of you are not aware of this, but P53, well, you know about P53. We thought that could, there was some data to suggest that P53 studied by immunohistochemistry could be a biomarker associated with worse outcomes. We looked at organ-confined cancers and randomized them to 3 cycles of MVAC versus observation with radical cystectomy. But we wrote in, it's interesting, if you go back and look at that, we wrote in that everybody had to have a bilateral pelvic node dissection and I think at least 15 lymph nodes. And so what I've put in here, this was work done by Doug Mata and Fritz von Rundstedt. He was a fellow with me. And look at the variability. This is in the context of a clinical trial where we handpicked the surgeons, all Skinner trained, And this is this huge variability in terms of the number of lymph nodes identified by the pathologist. And a third of them didn't meet the prescribed entry criteria of at least 15 lymph nodes. 15 was fairly arbitrary at the time. And two institutions drove the outcomes here in terms of extended use of PL&D. Guess which ones they were? Not surprised. USC and us, because we were obviously putting most of the patients on. But let me work through this. So there's been a clinical trial reported by the German group. So this is Jürgen Geschwend's. Jürgen is in Munich, and he actually has done the first randomized trial of, in this case, I think a misnomer of limited versus extended. I'll explain that in just a second. But this was a German trial, and this has been published now in European Urology. And I'll just walk you through this very briefly. It actually turns out to be probably an underpowered study. Roughly about 400 patients ultimately were eligible. And the other two caveats about this trial were that he included patients with T1 disease, and none of them got neoadjuvant chemotherapy. But it was a 5-year hard endpoint of overall survival, and you can see the curves on the right. They clearly show no difference between the two arms. So a negative trial. This is just my own assessment of why I think that it was some of the contributing factors to the fact that it was a negative trial. They've written that there may be a benefit in T2, but that was not a planned subset analysis, so it's currently hypothesis generating. All right, so been talking a lot about this. So we enrolled the first patient in August of 2011. So we were sitting around. One of the hats that I wear that Martin mentioned is I chair the local bladder committee in the Southwest Oncology Group, charged with developing and designing new clinical trials. And so we were having a leadership meeting, as we do at each of the twice-a-year group meetings. And Ian Thompson, you all know Ian, I suspect, who's our chair, he brought up this idea of doing a trial like this. And I kind of just jumped in and said, yeah, we should do it. And so we designed the trial. It's a larger study. The entry criteria require muscle invasion. We allow for neoadjuvant chemotherapy because the Southwest Oncology Group had done a randomized trial already, so we wanted to include that. And it was powered to detect about a 10% improvement in disease-free survival at 3 years between extended and standard. You've seen these pictures, and in patients with locally advanced disease pathologically who did not get neoadjuvant, we recommended, but did not require adjuvant. So we randomized 615, well, it's already registered 659 patients, completed it in 2017. And one of the unique aspects of this trial is all the surgeons had to be credentialed. So you had to submit 5 cases, and they're not necessarily consecutive, but 5 contemporary cases. You had to show intraoperative photos, and you had to send us your op report. We had a committee that reviewed every single case. And there were many surgeons who we went back to and said, not good enough. Imagine that. So I remember these conversations very distinctly about, I can't tell what you did in this op note. I mean, I can tell what you did, but it's not going to meet the bar that we set for the clinical trial. And then subsequent to this, we had 2 independent reviewers take a look at the first 100 patients in the clinical trial, and there was still a lot of variability. I ended up sending this, my dictation templates to one individual who's a good friend of mine, and then I started reading his op notes. It's like, wait a minute, that sounds just like my op note. But it's interesting so when you get into aspects of surgical quality, because we were very aware of the fact that ultimately when this gets published, the peer reviewers are logically going to ask, how can you verify that the patient had what they were supposed to have in the randomized arm? Anyway, probably more details. This is just the sample size calculations. I already showed that. I like to point out the high accruers, so this is really interesting. So Sia Danishman, I suspect most of you know Sia. He's a Skinner trained fellow, brilliant guy doing fantastic work at USC, and he's our biggest accruer. So when I talked to Sia about this, he said, yeah, I get it, I understand, it's equipoise. And the cool thing about this trial is it's an intraoperative randomization. So they get registered, based upon the clinical factors, and then you go to the operating room and you do your exploration, you make sure there's no lymph node metastasis outside the true pelvis, and then you hit the button and it comes back, okay, an extended in this patient, a standard in this patient. And Sia was all over this, and you can see that he far outpaced all the rest of us in accrual. And the other kind of cool thing about this is that 56% of patients got neoadjuvant chemotherapy. 88% of those patients got cisplatin-based chemotherapy. No one, at least until recently, had reported that level of uptake of the use of neoadjuvant chemotherapy. And I think it's particularly relevant in the context of a multi-center trial. So this is a comparison. LEA is the German trial, and our trial, we haven't reported the primary endpoint. Probably the earliest time point, I think, will be spring of next year, we hope. But
we're going to have 5 minutes before people are going to be knocking on the door.
Oh, okay. All right, so showed this already. Oh, okay. Yeah, well, let's see. So I talked about this already. So ERAS, Enhanced Recovery After Surgery Protocols. C has been a big leader in this, and the use of IV hydration as an outpatient. So we send patients home for about 30 days with IV fluids. The use of valvimipam in particular. And still, we're having a little bit of a challenge with the persistent mortality rate and readmission rate. But this is clearly providing evidence of improving the patient experience in the postoperative setting. This is just our algorithm that we follow in our hospital. We've worked very closely with the anesthesiologist, in particular for intraoperative management in terms of relative fluid restriction. Now everybody's getting 5,000 units of subcu heparin beforehand because of the well-documented incidence of VTE after, in particular, patients who got neoadjuvant chemotherapy. So Yoni Pinthas from Toronto has reported as high as a 17% VTE rate in these patients. And so it's a big deal. You hate to see a patient have a catastrophic VTE event after everything else has gone so well. And so that's helped a lot. There's this issue of blood transfusions. So we now, and I'm sure you have the same thing in Canada, the indications for, we have to follow very strict guidelines for blood transfusions. So a healthy patient with a hemoglobin of 7 or above is not going to get a blood transfusion, period. I can't even really get it in our hospital. So whether or not blood transfusions have an adverse impact on outcome is an important research question, but minimizing blood loss and using intraoperative controlled hypotension and then minimizing the use of blood transfusions postoperatively may show some benefit. I think I showed this already. Yeah, okay, here we are, the end. All right, so I won't belabor some of the points that I've been making, but I hope that I've taught you a little bit about our role as surgeons in quality, pathologic outcomes, and how we use this information to drive decision making. So thanks so much.